Could I draw attention to somebody else who's in the room who's very, very important for us? That's Lisa Cullen, who's the nurse working out of St. Vincent's Hospital and who's a very, very important contact point for us. And as well as that, could I offer some feedback on our experiences to date? From our session this morning, there's still an issue about who is the go-to person if you have this disease. Who is the go-to person in your county, in your region? And we'd love to get to a situation. Already here around the table we have people from Cork, we've somebody from Galway, and we've people from Dublin. And we'd love to get to the situation where we'll have someone from Limerick as part of this group and maybe somebody from Waterford as part of this group, so that when somebody hears they have a carcinoid problem, they know where to go and how that's going to be channeled into the multidisciplinary team. Second thing is in relation to our experience when we are going through recognised experts. One of the beauties about being able to compare is you can maybe learn where things are better and where things can be improved. And it's still a bit of an issue for us that if you come for bloods and urines, whether scans are going to be the same day, what sort of scans you're getting, and when you're going to get results. And that's something that, you know, those of us who go to Uppsala, we're used to it being much more refined. And just from a practical point of view, it's difficult if you're trying to live a normal life, get on with it, deal with the disease, but if you're having to take 2 or 3 trips and then maybe wait 4 or 5 weeks to get the results of those 2 or 3 trips. So I know that you're working towards refining that, and that would be a really major advance. Third thing, and this is a sad but valid observation, that it's not just a question of who is the go-to person in the county or the region. Sometimes it's who is the go-to person in a hospital, because there are people here who are being treated in hospitals, and very big hospitals.
I think the first thing is to recognise that there are legacy issues in Ireland with regards to the treatment of neuroendocrine patients. That's very clear from what you've stated publicly. I think that you know, if you look around the table, the average age, I'd say, of most of the consultants that are up here are in their mid to late 40s. Most of us have come back, with the exception maybe of Mr. Gagan.
I'll take that.
What I'm trying to say is that many of us have come back. I came back to Cork 7 years ago. There was no neuroendocrine group to speak of, and patients, you know, ultimately start coming to you because they hear you've got an interest in that, and it's really by word of mouth that spreads out. We're now moved significantly on from that. I think there is a good working relationship between the various different people in this country that have an interest in the condition. There's only, you know, I won't say a handful of us, but slightly bigger than a handful of us around. We've met on a number of occasions. Some of us are surgeons, some of us are oncologists, some of us are radiologists and pathologists. They're not all represented here today. What we're really trying to do is to win back, to a large extent, the confidence of patients who have this condition in this country, and to plot a path forward from here. I think it would be fair to say, and I get Justin's opinion on this, that there's very little in terms of surgery that cannot be offered in this country today. And that's with all due respect to Per and his experience and so on. But in terms of the surgery that's there, you know, particularly for pancreatic and for gastrointestinal net tumours, the expertise is in the country. In terms of you know, chemotherapeutic options, again, most of the options are there. It's with regards lutetium and the gentleman who addressed that question, and we're working towards that. But I think what we're trying to do is cooperate together. We're trying to establish a national meeting whereby patients who come to us in Cork or who arrive in Dublin or arrive in Galway are fed into that multidisciplinary team meeting. So it is not just the team in Cork that are deciding on that patient, or the team in Vincent's, or the team in Galway, but it's nationally we're coming up with what the treatment plan should be for that patient. And I think it's very important to say is we want this process to be as transparent as we possibly can. If somebody needs to travel abroad, there's no issue with that. There's absolutely no issue with that. But equally, I think we need to advise patients or be in a position whereby where they're advocates and they're advisors and say this is appropriate for you to be treated abroad. unfortunately, I think there is the concept that, you know, what's being offered in Ireland is substandard or is not good enough. And I think we're trying desperately to change that. So that's the first thing. The second thing, with regards organising the scans, the urines and the bloods, it is difficult because, you know, you're going to your radiology colleagues, you're establishing a date for a scan to be done. You then oftentimes, if it's a 24-hour sample or whatever, are trying to coordinate that. But with the appointment of clinical nurse specialists in neuroendocrine, I certainly think that the coordination of that aspect of things could be significantly improved upon. So that's where I think we are.
Tommy, as you know, I worked in London for many years as a consultant in King's, which is now a centre of excellence for neuroendocrine tumours. And I think one thing I can reassure everyone is one of the things, not that I was surprised when I moved back to Ireland, but all of the expertise is here for treating these diseases. And I think, you know, if someone saw myself, Chris, Derek, or anybody on this table, the treatment they would get in Cork or Dublin or Galway is the exact same they would get in any hospital in London. You know, in our MDT in London, it's the exact same treatment. And I think I can reassure people, not having had the experience of working in London. So I think, just to mirror Chris's point, that I think things are getting there. And I think, you know, certainly the surgical expertise is there. But now it's kind of, I mean, there's two national pancreatic centres in Vincent's with a satellite unit in Cork. I think it's fair to say liver surgery will probably follow suit in time, because that's where the liver surgeons are as well. So I think you've got you know, there is a structure developing over a number of years. So I think, you know, the expertise is in Ireland for any surgery. And as Chris say, we've all worked abroad in the biggest centres in the world, London, you know, Paris, and the States. And I think people will be referred for any treatment or test that we would deem necessary. So I think it's exciting, actually, you know, from our meeting this morning.
So, Tommy, just in answer to your first question about a go-to person, I mean, I think there's go-to people, and there's many of them here. I don't think it's reasonable to suggest, you know, for a population of 4 point whatever million, that there's one go-to person. I think there should always be go-to people, and many of them are here, and a few of them aren't represented here. And every doctor in the country shouldn't be treating carcinoid tumours or neuroendocrine tumours. There should be a set of people, and I think that's a testament to Dermot's work and Mark's work here, trying to set up the likes of this. All our names will be on the website. There'll be referral pathways, and the streamlining of referrals, which I absolutely agree has been hugely problematic, even within individual hospitals, will be very much ironed out thanks to this initiative. And I think that's becoming very obvious to me, certainly in the last 2 years. The final question about the prescriptions, I'm a pharmacist as well, as you know. I used to be in a former life, so that's a legal thing. The Pharmaceutical Society of Ireland have said, and there's reasons for this, that every prescription has to be renewed at least every 6 months. And the reasons for this are patients can get a prescription for a year and never see a medical person and keep taking the drug. So the 6-month thing is from the Pharmaceutical Society of Ireland, and that's a forensic medicine law. So if we were to consider changing that for medications such as sandostatin, lanreotide, etc., it would have to go through the regulatory channel from the Pharmaceutical Society of Ireland side to change that. But I think the logic of it is good, but the concern is that patients wouldn't link in with their doctors, and they're drifting in the community, having seen no one for a year.
Yeah, I mean, I reiterate that. I mean, but I think that the most patient that I see, and I've prescribed a lot of sandostatin and lanreotide, I don't get a problem with that, because usually, you know, the patients ring my secretary, send an email, it's sent out a month in advance or whatever, and we date the thing. So that shouldn't be an issue. And I think that it goes hand in hand with getting access to your go-to person. So if you've got a go-to person that you know well and is going to have no problems, so you shouldn't be seeing your standard physician or your NET specialist to get your prescription. I mean, it's that can be streamlined, of course, and getting around it. 6 months is not bad. In some countries, it's not as good, in fairness. I think the real issue really is, and I would all the speakers I agree with, but it's Tommy, I don't want a guy in Wexford and Waterford, in my opinion. I think you're getting back into what we're trying to get away from. We have 3 groups concentrating the energy with regional expertise. We've got 8 cancer centres. So I think the answer to how do you get to the go-to person is perhaps by us being a little bit more proactive and trying to push and promote this. And I think the way, and we agreed with this morning, is probably through the NCCP. Now, as I mentioned, sort of, working in James and Vincent's, getting to that sort of footing was not very easy, and thanks a lot to Justin and to Donal as well for helping set this up. But even since we had this announcement of the NCCP initiative earlier this year, I mean, the referral patterns have changed a lot. So in the Vincent's group, let's say in the Dublin group, we're seeing more and more patients, and I think that's been, for us, reassuring. And I think this will help as well as we go back and we go through the NCCP, now Susan O'Reilly, for example, to sort of say to the 8 oncology groups, well, there we have these regional groups now looking after this, so that oncologists and surgeons and other physicians around the country will know that, well, there we go, Chris Stores down in Cork or Derrick, that patient down there should be going to see them. And I think that's how we can improve on getting to the go-to person. And I think it's the right way to go about it. We obviously have to have a formal structure in place to be able to provide that. Some of you were at the meeting last year when we spoke about this, and Susan O'Reilly was correct in saying that if you open up the floodgates straight away and we're not ready to take patients on board and accommodate you and your worries and your issues, that would be wrong as well. So we've got to go about it a little bit slowly, but we're in place now and we can accommodate that. So I think we've made good progress. We've got a good bit to go, but I think that we can now formalize that process through the oncology centres and become, let's say, more apparent.
Just one other thing, Tommy, that I think is very important to say, and that's that it's not just the diagnosis and initial treatment of the patient, but it's actually the follow-up of that patient. And, thankfully, many of the patients in this room will hopefully live a very long time. But it's actually following up those patients and managing those patients during the journey of their neuroendocrine tumour. That's actually the big challenge. That's actually the challenge is making sure that they're followed up regularly, appropriately, and managed correctly into the future.